Good morning. Now that you have the translation, I hope you can enjoy our course today. It's a pleasure being here, and I want to thank Dr. Speranza and NEA BPD for hosting me. This is my first time in Paris, and it's really an amazing place, and I agree that the French may be superior to the Americans. So I'm here to teach you about good psychiatric management for adolescents. And I had heard this morning that, this is a new generation of professionals, and many of you are starting your careers. Maybe you haven't heard of John Gunderson, who was my mentor, but he was only 3 years out of residency when he did a review of the literature at the time and put together a synthesis that defined what we now know as the symptoms of BPD. So it's really out of the belief that new ideas in young people can change a field over time. It took him 40 years to really work towards establishing legitimacy of the diagnosis, but it really goes to show that people can change the way that we practice. So I hope this gives you some good enough ideas to be prepared to treat patients with borderline personality disorder, because as a psychiatric professional, you will see them. So as an introduction, good psychiatric management is called so because it follows a medical model. And in the medical model, we assume that patients with most psychiatric diagnoses, especially those as prevalent, serious, disabling, and potentially fatal as borderline personality disorder, is a disorder that most professionals should learn how to treat. So patients with the disorder should be able to assume that those who are treating them have been trained to do so. And like other illnesses, they should also assume that early detection and intervention is possible, and the diagnosis and the treatment of borderline personality disorder is not a last resort. We oftentimes wait too long to diagnose this disorder after personalities have already solidified, and then it's much harder at the time and lends towards the negative reputation that these patients unfortunately carry. But there are many reasons that we need to be more generalized in our knowledge of how to treat BPD. Because first of all, it's a highly prevalent psychiatric disorder, even among adolescents. So the rate of prevalence in both adult and adolescent samples is about 1 to 3%. It's more common than schizophrenia, and about as common as other illnesses such as obsessive compulsive disorder and bipolar disorder. Furthermore, these patients seek care. In the outpatient clinics, about 10 to 20% of those adolescents seeking psychiatric care will meet the diagnosis of borderline personality disorder, and this is more common in inpatient units. Those patients for whom outpatient care is not enough may also have this disorder. The second set of reasons that we need more clinicians to be trained in treating BPD is that over time, untreated BPD leads to negative outcomes. We know that the diagnosis is associated with functional impairments, disability, and a loss of hope over time that treatment can work. When young people have been treated for a variety of other problems they have, depression, anxiety, school problems, family problems, social problems, and don't get better, they start to lose hope that any treatment can work. So all of psychiatry, but especially child psychiatry, needs to adopt the diagnosis. There's a myth that you can't diagnose BPD before the age of 18, But that's always been a misunderstanding. Even in the earliest versions of the DSM-3, the diagnosis of BPD has been allowed. You'd have to meet criteria for a year before making that diagnosis. And the adolescent period is one in which identity begins to be formed. And this is actually very important for the development of personality functioning. So if you intervene earlier and support these vulnerable people earlier, they'll do better. But at the current moment, there's a lack of treatments for those who are adolescent with BPD, even more so than adults with BPD. And treaters or clinical professionals generally lack the access to training that they'll need to be equipped to work with these patients who may seem severe and challenging first, but end up being highly rewarding with a full potential to reach recovery and rehabilitate. So there are other reasons that I want to promote early intervention. We know that early BPD symptoms, even when they're developing and don't reach full diagnostic criteria, often starts to co-occur with other disorders and predict their development. They also tend to predict the need for continued services. In adults, even having one symptom of BPD elevates your risk for developing ongoing chronic depression, anxiety, inpatient hospitalizations, and suicide attempts. So when you detect these symptoms early, intervening is likely to diminish the risk of these ongoing problems. Furthermore, these problems actually will increase the challenges to families who bear them, and it will create poorer relationships over time and financial stress and burden on the family. So having a child who has the kind of sensitive temperament that increases the risk for BPD is compounded by having the ongoing stressors of having the difficulty finding treatment that will be helpful. BPD also predicts school outcomes and the ability to use the social environment to grow up. And that eventually leads to impairment in adulthood. So BPD patients, we've understood from the adult research literature, actually benefit from more informed treatments. In the US, I'm on the APA Guidelines Committee. So the guidelines on borderline personality disorder were first written in 2001. We're only now revising them. The state of the literature is, though, much more developed, but still limited, and even more so for adolescents. But what we do know is treatments that were built specifically for the problem of BPD are more effective than treatments as usual for this population. But as I said, the diagnosis and treatment of BPD is not done routinely. As we see here, there might be one doctor in the hospital who is doing it, or one group providing BPD treatment in a region that expands, and the demand usually exceeds the supply. Most clinicians treating youth don't feel comfortable with the diagnosis and often can't find referrals to relevant treatments. And training and approaches to BPD is not typically available, and I think you'll agree with that. There are treatments that are well known for BPD, like dialectical behavioral therapy and mentalization-based treatments, but as someone who's trained others in these modalities and used them myself, they're very intensive and specialized and require a lot of support to administer them. So even in places where there is kind of widespread knowledge that BPD is a legitimate diagnosis, even in use. The practice of diagnosing BPD is quite low. In the UK, 32% of adolescent psychiatrists will consider BPD valid in adolescence, so there's many who don't. And even more so in a place like the Netherlands, which has centers of excellence for personality disorder treatment, most clinicians will acknowledge that it's valid in adolescence, but only a fraction will diagnose it, partly because there aren't many treatments available. But the other reason that the diagnosis is avoided is because there are misunderstandings or myths about the treatment of BPD. The first is something that's written in the Diagnostic Statistical Manual, which is that personality disorders are enduring, inflexible, and pervasive. We now know from longitudinal studies that this is actually not true. People in their adolescence especially will move in and out of meeting criteria for this diagnosis because personality functioning is highly malleable in the earlier phases of life and solidify and change over time in adaptation to one's life experience. Some personality features are more enduring than others, but the ones that we know remit quickly and are highly context dependent and changeable are those that are associated with BPD. The second myth is that BPD patients only improve if they're given extended, intensive expert treatments like dialectical behavioral therapy or mentalization-based treatment. And that's also not shown to be true, and I'll tell you a little bit more about that. These treatments are only going to be required for a subsample of patients, especially if we intervene early. Whoops. There's another myth that all teenagers are a bit borderline. And while it's true that BPD symptoms normatively increase during adolescence and then decline, there are a population of teens that are more severe in their traits, and they can be identified early. Those individuals tend to stay at high levels of BPD symptoms and continue to maintain that level of symptomatology over the course of their development, while their peers will increase in those symptoms and then remit as they grow up and mature. The fourth myth is that BPD is a product of abuse and maltreatment. There are high rates of trauma among those who have BPD, and this is a complicated issue. BPD results from an interaction between temperamental and neurobiological endowments in children and the caretaking environment with which they interact. So if you think about it like economics, demand and supply cross, determining the price. So if the demands or challenges on an individual exceed the supply of support, the price will be higher to that individual, and they'll show more distress, difficulty, and challenges coping. And for each individual, this equation is different. And you can find out what it means if you don't enter the clinical scenario with an assumption that the person has been abused. The fifth myth is that BPD patients resist treatment and angrily attack their treaters. While it is true that patients with BPD may be quite expressive of their distress and express anger intensely, that's a symptom of the disorder. And we try to teach people that it's not just what you're doing that determines this outcome. This is a serious misunderstanding, and because these patients are more emotionally and interpersonally sensitive, their strong reactions are oftentimes interpreted as someone doing something wrong to them. And that may not be the case. The sixth myth is that recurrent risk of suicide burdens treaters with excessive responsibility and ongoing risk of litigation. We worry about this a lot in the But the truth is, if you have a reasonable, informed, structured, and systematic approach to taking care of patients, just like if you were an oncologist, a dermatologist, or any sort of medical professional, if you follow the standards of practice, then you can actually justify your decision-making over time. If you don't centralize the diagnosis, it's much harder to do so. So the risk of litigation is often a burden of a failing treatment and a worried clinician. And there are ways in which you can support your work by having some set or structured framework from which you operate. These days, there's a lot of controversy in the field about how to diagnose BPD. So there's the model that is the traditional model of categorical diagnosis. I think this comes from the medical discipline because the early diagnostic criteria was mostly built by psychiatrists in committee. And like other disorders, it's a matter of reaching a certain threshold to become either borderline or not borderline. There are, like with any model of diagnosis, strengths and limitations of this. Nowadays, there is the rise of the dimensional model, and this is really rooted in the discipline of psychology, where they study more broadly how human psychology functions. So there's normal personality functioning and more pathological functioning, and this is also useful. And what they focus on in the alternative model for personality disorder is that personality disorders in general are a problem of self-management, identity, self-esteem, coping capacities, as well as interpersonal relating. So what we say now about how to manage, to treat personality disorder, which I think is really useful, especially in early intervention, is to think towards what we call salutogenesis, trying to promote healthy personality functioning, not just intervene when you can detect pathology. And there's a kind of idea that was introduced by Antonovsky about salutogenesis, is that there are three main ingredients about increasing resiliency in people across medical illnesses. It is to enhance a sense of meaningfulness, that there's a motivation that's available to cope with whatever problem the patient has, as well as comprehensibility, that there's a belief that the challenges they have can be understood by themselves and others. And lastly, a kind of ability for that problem to be manageable. That is the belief that there are resources, supports, treatments, and interventions to cope with the problem at hand. So this intervention for BPD can help young people, regardless of how long they meet criteria, to be healthier in their personality functioning. And there are, in fact, studies among youth that show that those who have been in therapy earlier in their lives have better interpersonal skills in the long run than their peers who have never received therapy. So in the alternative model, we think about different aspects of self and interpersonal functioning that you can also think about in your work with patients. First of all, we know that in borderline personality disorder and compromised personality disorder in general, there are problems of identity functioning where the identity is impoverished, unstable, and empty. These are key features that distinguish those with BPD from those without. And also difficulties with self-direction, and this is related. If you don't know who you are, being able to construct authentic or personally meaningful goals, aspirations, and values is difficult, and these two problems interact. That when you don't have goals and values, then you don't have a stable sense of self. So this is very crippling, if you can imagine it. Secondarily, there are related problems of interpersonal interpersonal functioning. If you have problems of self, your relationship with others will be disturbed. First of all, you'll have difficulty empathizing with others, understanding how they work, because you don't even understand how you work. So you may become more paranoid, more sensitive, and more dependent on others, which is a conflict in of itself when you fear them and need them at the same time. Furthermore, it's difficult to get close to people. And this is actually an important milestone developmentally in adolescence. Erickson talked about intimacy and identity. These are tasks of that period of young adulthood. So the qualities of having BPD, where you have unstable, needy, fearful tendencies, combined with this kind of frantic panic in the face of abandonment and idealization versus devaluation, you know your relationships will be fraught and unstable. So in this new model of personality disorder diagnosis, which I think can coexist with the categorical model, we think of these problems of self and other as kind of the gateway to understanding there's disturbances in personality functioning, and then there's criteria B that are the traits of the disorder. Research by Carla Sharp has suggested that BPD symptoms represent a general factor of psychopathology in personality functioning. She did a study of over 1,000 patients at the Menninger Clinic and did a factor analysis looking at the ways that the different symptoms of the different personality disorder loaded onto different factors. And while the features of disorders such as obsessive compulsive personality disorder, avoidant personality disorder, and antisocial personality disorder, for instance, loaded onto those specific disorders, almost all the features of BPD loaded onto a general factor. So these features of BPD represent what interferes with healthy, stable, and functional personality mechanisms. So GPM then might be particularly relevant for all personality disorders because it is designed for BPD and furthermore really focuses on functioning in life context and adapting to the world with the special sensitivities that one has. It's a part of your personality. Because what we want to do in early intervention is to avoid the Bergson bias. Most people understand personality disorder from their interactions with the patients in the emergency room that we call frequent flyers. Those patients represent only a subset of those with BPD. They're the ones that don't respond to treatment. So these are the patients that are more chronic and treatment resistant and likely to stay in treatment, whereas most patients will get the care they need and leave. You don't see those as often. So what we want to do is we want to intervene before adolescents rise to the occasion of the Bergson bias and become those patients that have now represented or typified BPD to most clinicians. This idea is depicted in this cartoon of Calvin and Hobbes, that it really starts that engine of individuals learning that they have to make some sort of explosive statement to get other people to understand them. And that becomes reinforced over time when there's a failure to understand that someone has the problems of BPD. So do you remember when I was saying to you there is a myth that all teenagers are a bit borderline? That comes from a basic fact, that there's a normative rise of BPD symptoms around the age of 8 or 9, and it peaks at around 14 to 16, and then goes down. So the period of adolescence is one of enormous changes in the brain and adaptation in the bridge between childhood and dependency towards adulthood and responsibility. It's an incredibly stressful, transformative, and busy time. And so what happens over this time is that kids are released into the world with no skills, and they are impulsive, emotional, and sensitive, and misdirected, make mistakes, and they learn from them. And this is when they develop a sense of self. And that sense of identity then starts to kind of adjust and modulate all of their emotions and their behaviors and their interactions with others so that these BPD symptoms get contained. And that happens concomitantly with myelination and changes in the brain, so that there's more connectivity between the different parts of the brain, so that the functions of their cognition become better orchestrated. But as I explained to you, there will be a subset of people who have traits that are elevated. And we understand from studying people across time that for these individuals, they'll stay elevated for the most part. And the problem here is not just first the burden of having impulsivity, self-destructiveness, emotional reactivity, and interpersonal instability, if that's not enough of a problem. But then there's this problem that their distance from their peers become more aggravated, and they become outliers or outsiders to the world. And they don't have the capacity to learn coping skills and the things they need to acquire in order to become an adult. This is why we oftentimes call people with BPD primitive, immature, or underdeveloped. So the goal is that if we can intervene earlier and bring down the burden of these symptoms, that may also relieve the sense of alienation these folks feel from their peers and from society in general. Because if you're on the outside of society, you have to make a lot of noise in order to be heard. If you're on the outside of society, you don't want to live because you don't know if you'll survive. Belonging is an important buffer to the challenges of life. So many of my colleagues, like Andrew Chanin, Carla Sharp, and others, have really introduced this idea that we have to intervene earlier. If someone had diabetes, we'd intervene right away as soon as it's detected. If someone had cancer, you want to intervene when you can still isolate it so that its effects aren't more damaging or fatal. So there has been a lot of literature in the early 2000s about early intervention, which has been pretty controversial over time. But we now know from the growing scientific literature that BPD can be reliably diagnosed in early life. Many studies have been shown that the diagnosis of BPD is just as valid during adolescence as it is in later stages. And it's just as prevalent in clinical practice, as I've said to you. But this is where the functional disabilities for these individuals begin early, and it starts to make them feel broken beyond repair and like they can't do anything. And in the adolescent period, you have to be a little bit grandiose and self-confident to face life in and of itself. And so they lack that kind of impetus or motivation and self-confidence to take risks and make attempts at things that will fuel their sense of self and pave a path to the future. Furthermore, we know personality is malleable. You see teens, one week they'll kind of dress in a certain manner, and then maybe 6 months later they're a totally different version of themselves. So we want to take advantage of that period where it's normal to try to on different versions of yourself and transform. And we also know that this disorder responds to interventions. So how do we know this? I'm not going to go into detail, but there were some adaptations of the specialized treatments that were done that showed that they had some advantages, but actually the advantages of MBT and DBT over treatment as usual in this literature is less robust than in adults. And it's probably because teens are more adaptive and it's early intervention. So what we see in this literature is that when DBT is compared to something called enhanced usual care, at first the self-harm decreases faster. But over 3 years' time, the outcomes for the two groups is about the same. So it's a more tumultuous course, not getting DBT, but at the end of that period, what the hopeful news is that these patients can get better if they're understood as patients with BPD. So we know that a lot of these specialized treatments that have been built for BPD in adolescents are about similar or comparable to usual treatment. So I think that this shows us that teens need less intensive, shorter treatments to get better. So through evaluation of the literature, we know that early intervention is feasible and effective. It doesn't matter how specialized and generalist approaches work. And we also know that at baseline, we should do something like GPM, just good management for the treatment of BPD, because it's unclear how that kind of extra investment in DBT or MBT works. It probably is best for those who have very serious self-harm, because that's what it's proven to work best for. And we also know that brief, structured, well-specified, that means like a kind of manualized or protocolized approach, works, and it can produce substantial changes. Now that we know a lot of things do work, we have to understand why they work. And I think that there's actually some common factors here amongst these different approaches that are more important than the specific factors. So there are some principles across psychotherapies that are common. And this is from an article written by Marvin Goldfried. And he was actually a teacher of Marsha Linehan. And when I wrote a paper called Debranding Treatments for Borderline Personality Disorder, he called me and he said, this is really great news. People get so specialized and so kind of obsessed with the details, but that's actually not the important part in treatment. The important parts are these: that you want to promote the patient's expectation and hope that therapy can help by speaking to something that resonates for them. They have to see their problem in the treatment that you have to offer them. And then the treatment has to be modeled around trying to maintain an optimal therapeutic alliance. That's why paying attention to BPD, because of its interpersonal instabilities, is really important. It steadies you in that relationship. You also have to facilitate the client's awareness of the factors associated with their difficulties. All patients need to know what their symptoms are, to know how much better or worse they're doing. And you want to encourage the patient to engage in corrective life experiences. If you've had BPD and you feel like you mess everything up because of your disorder, helping them to do it differently and see that the outcome can be different is corrective. It actually starts to repair their wounds and their scars from having had so many failed experiences. And you also at the same time want to help them be realistic. GPM is above all things reality-based, and much of psychotherapy helps people cope with reality. You know the meme these days that's like expectation versus reality? I think psychotherapy is simply something that helps people deal with the gap between expectation and reality. So the whole idea of step care actually was inspired for me and, in the field by the work of Andrew Chanin, who said that BPD should be just like any other illness that has stages for which you apply different interventions. So for cancer, you determine what the treatment is by the stage and the advancement of the illness. So you'll do the same for BPD. And I've revised this kind of model to look at the different kinds of categories we think about in terms of BPD. So when someone's not meeting full criteria and they're preclinical or adolescent, you really just need to provide some psychoeducation and support for families. Maybe you'll do some psychoeducational groups. And if they go on to have more severe symptoms like self-harm specifically, which is quite common among adolescents, you will do some GPM and case management and support their families. Families don't know what to do with self-harm. Most physicians are shocked by self-harm. So giving them some information so that they can cope and support their child in a way that will help them manage optimally is important. And you really don't need more formal treatment until they enter this sustained moderate or severe period. Now, the last part of this model is those frequent flyers, the people who are always in the emergency room or always in the hospital. Actually, that's where you do less treatment. You just provide supportive care. It's almost like social assistance for people who have a disability related to BPD. You don't give those people this intensive change-oriented treatment. They probably already had it, and they're doing the best they can, and they just need some support to live and survive. So how do we know GPM works? Actually, this is a discovery by accident. When DBT was studied by an investigator outside of Marshall Linehan's lab in a large, rigorous, randomized controlled trial, the key investigator, Shelley McMahon, wanted to have a decent comparison treatment. Because if you compare 5 hours of treatment, like DBT, to terrible treatment, as usual, who's going to win? Probably DBT. But if you compare DBT to a treatment that's less intensive, informed, predictable, and applied by people who like to work with patients with BPD and know something about it, actually the differences aren't that significant. And that was what was found in this trial. It's one of the largest trials done to date. And I think that Shelley McMahon was rather brave in publishing this. Because what they found was that both treatments decreased hospitalization, self-harm, and depression and anxiety across different outcomes. They were statistically comparable. But because GPM pays attention to psychiatric comorbidities and DBT doesn't, GPM did better at retaining patients with comorbidities than DBT. So what's the structure of GPM? It's once weekly if useful, and you use the equipment you have. If you have medications or need them, you can use them in a reasonable way. If there's family interventions like NEA, BPD, Family Connections, use it. Anything works. We're flexible and practical. So the specific features of GPM include diagnostic disclosure. This is a right that patients have. It's considered malpractice if you don't tell a patient that they have cancer. And the same should be true of BPD because it's fatal in some cases, disabling, but treatable, especially if you intervene early. You want to teach people that they have an interpersonal hypersensitivity problem that explains all their symptoms. Just like when you explain to people that have diabetes, they have an insulin insufficiency. So that causes them all the visible, observable features of diabetes. And that will help them to change and modify their behavior to optimize their health and minimize their symptoms. You want to not just make therapy the precious zone of focus, because people with BPD are already interpersonally sensitive. So they're easily attached and prone to exclusive relationships, and they will have this point of view that they need that person to survive. But what GPM does is try to reverse this and teach people, no, actually I'm not doing a good job for you unless you learn how to live your life as it is outside of the office. My job is to teach you the lessons and instill the confidence in you to take on usual life challenges with your interpersonal hypersensitivity. And this is founded in psychoeducation about the causes, the natural course, and the social difficulties that people with BPD will have. And the treatment is evaluated not by how much the person likes you or understands you, but by progress. Any medical intervention should be evaluated based on how effective it is at reducing symptoms and increasing functioning. And the good news is GPM is adaptable no matter what your orientation is. It has psychodynamic ideas. John Gunderson was a psychoanalyst by training, but he was also a scientist and a skeptic. And he really embraced the practicality of behavioral therapies that focused on changing how a person acts, not just changing their understanding of themselves. And most importantly, it really focused on the involvement of families. They are the family that the patient has. Doctors or clinicians or therapists come and go. So you want to instill some useful skills and knowledge for the family or the support system as they exist. So the adaptations of adult GPM include the inclusion of patients who are beginning to have BPD. So they may be sub-threshold, the translation of material in a way that these patients can relate to and understand it, participations of families as far as they're willing. Your job as a clinician is to just offer it and making recommendations. Their job is to decide what to do with it. The treatment length should be shortened because you want to get the young person back to the environment that they have to grow up in. And you also make developmental considerations like identity functions, autonomy issues, and the kind of concerns of getting along with their peers. So teens are so preoccupied with all this, you want to take advantage of that and tell them that the treatment you have to offer will make them better at relating to people. So then, where does this leave you with all the other treatments? GPM represents what all treaters should know about BPD, no matter how specialized you get. It's like laundry detergent. They all say they do different things, but they all clean the laundry, right? So it's good enough for most patients, and those who need or want more can get these other treatments if they're available. So just quickly, I'm just going to go on to the core idea, which is interpersonal hypersensitivity. So every treatment that has been built for BPD that's been effective has a core formulation of what BPD is about. And we know that during our life course, relationships cause us a lot of grief, right? If you ever have a conflict with someone, it stays on your mind more than you want it to. And it produces the emotions that we then associate with emotional dysregulation. So when these things happen, for all of us, we become very volatile, and it's like we're on a roller coaster. But for those with BPD, it's more aggravated and felt more intensely. So do you know this movie, Mean Girls? Yeah. Okay, good. It's a universal phenomenon, Mean Girls. So in the transition to adolescence, there is this transition to having more responsibility and demand. When you're before adolescence, kids are like kind of coddled, right? Everyone adapts to them. Everyone looks after them. Everyone's nice to them, usually. But in your teen years, all of a sudden, your coaches are yelling at you. Your teachers want more complicated work. You have to compete with others more actively, and the social world is chaotic. You don't know who's nice, who's not nice, what's going to happen one minute or the next minute. And then you have your parents who you become a little bit disillusioned with. You don't like them as much as you used to. And the job of adolescence is to be able to kind of internalize our relationships with others, so that we can kind of separate and individuate. So interpersonal relationships are a source of self. They're both within us. Our self-experience and sense of self comes from our interactions with others. When you become a doctor, you only feel like a doctor because people are like, doctor, tell me what to do. Because there's a social interaction in which your identity is formed. And this is defined by the type of relationship. So as you grow up and you become a doctor and a parent and a partner and, you know, a parent and a grandparent and an aunt, all these features of oneself become your identity. But in adolescence, people are troubled by the volatility of their own brains. So this is a comic of the anatomy of the teen brain. And in reality, what really happens in the teen brain is that there's a lot of pruning and restructuring. And people are impulsive at this period because they have more freedom to act on their own and make their own decisions. But the kind of connectivity between the thinking part of the brain and the acting part of the brain are just kind of starting to remodel. So actually, my friend who's an expert in the teen brain and substance use said that, you know, in adults, when you're testing their sobriety, you do this kind of thing. Teens can do that because their kind of physical, kind of anatomical brain is more tightly wired. But if you ask them to do math, they can't do it. So if you are trying to tell if your teen is intoxicated, you ask them to do math, not physical acts. So what you do in the, with the teen is you understand that they're moving from a dependency on adults to independence with these very treacherous peers. So there's a bridge, and successful development really relies on being able to kind of modulate your way back and forth. You go back to your parents when you need them, but then you go out on your own when that's called for. And so for the adolescents, they're going to have a lot of dilemmas about, do I rely on adults or do I bond with my peers? But for those who have BPD, this is more difficult. It's like that bridge is on fire. And they run to being more dependent or more independent. And that's a real dilemma for everyone involved. So, how do we know scientifically this to be true? We also know that BPD is actually heritable. The degree of heritability is quite high. It's higher than depression, but lower than schizophrenia and bipolar disorder. So about half of the variance of the risk to become borderline comes from genetics. We also know that interpersonal features are what distinguishes those with BPD most from those who have other disorders. The core diagnostic features are a desire for exclusive relationships. So this is something that Catherine Winsper found in her longitudinal study in the UK, is that those who had exclusive relationships, like one best friend at a time, were more likely to develop BPD. Girls tend to not be as sure of themselves or have some confidence or clarity about who they are. They may have chronic feelings of emptiness, inappropriate, intense anger, more so than what's usual for teens, and in boys, more paranoid ideation. And boys are more aggressive in general, so maybe they have reason to be paranoid if you see the play of boys versus the play of girls in a typical way, but that's not always kind of just following stereotypes. So the interpersonal events we know trigger the core features of BPD. You'll see them here. Also, we know that childhood disorganized attachment, separation problems, and attachment tendencies tend to predict adolescent BPD. And the genetic vulnerabilities that make them more stress sensitive and more disturbed in their bonding tendencies are disturbed in BPD. So this is really the end here, is that the coherence of all the symptoms of BPD really has to do with how related you are to others or how connected you are to others. So everybody knows who this is, Taylor Swift? Okay. More people know Taylor Swift than John Gunderson. So this is a music video that depicts how much Taylor Swift relates to having borderline personality disorder, because there is a period where she's living her dream, she's very happy, but something threatens her and she becomes more angry, and then she withdraws because of the intensity, and then there's a sense of despair and meaninglessness. And that is really the kind of interpersonal oscillation that occurs that makes the symptoms of BPD change. So what we say is, for adolescents, we've put this in terms of rejection sensitivity, actual rejection, and being socially disconnected. Because actually what happens is they fear being rejected, and then they act in these hypervigilant ways. And then when they think they're being rejected, they act in a way that pushes other people away. And when they're without others, because they're so dependent, they feel completely uncontained and lost. And that's why they become impulsive, self-destructive, and sometimes suicidal. And the truth is that if you actually have people start to show concern because they're so self-destructive, then they actually feel more connected, and then they'll be okay. But this isn't a treatment plan, because this just creates instability. What we're saying in GPM is that you want to lean in when they're angry, okay? Because that's where you work out the problem and you try to understand them, then react to them. I'm going to skip this. So there's a lot of difficulties adolescents uniquely have, especially in the digital age, where there's more modes of being isolated, criticized, and rejected. But the implications of all of this are that these interpersonal sensitivities will define the features you see in these patients. And so the emotional and behavioral discontrol or dysregulation is secondary to how stable their relationships are. You want to proactively connect symptoms to something that happened for them. Don't wait for them to tell you. And then their action or inaction. The action or inaction of other people will trigger their sudden unexpected responses that reflect these oscillation and symptom states. So we tell people what this means is that you were born with hypersensitivities that would make it difficult for others to respond in ways that you find helpful. Okay.